Hi everybody, my name is Hashim Ghazi. I'm an interventional cardiologist, and today I'm going to talk to you about COVID. I am doing a structural interventional cardiology fellowship currently at Cedars-Sinai Medical Center in Los Angeles, and I did my core interventional cardiology fellowship at Beth Israel Deaconess Medical Center, affiliated with Harvard Medical School. I've taught Harvard Medical students human physiology. As a disclaimer, I should mention that this is not personal medical advice. The first thing I wanted to quickly clear up is the difference between the flu and coronavirus, because this came up quite a lot initially when we first started talking about coronavirus. There are many causes for upper respiratory tract infections. They include fungal infections, which usually happen in immunocompromised people, bacterial infections, and of course, the viral infections. Now, 85% of common colds are caused by rhinovirus, but you might be surprised to hear that about the rest of 10-15% of common colds that we've been having for the past several decades have actually been caused by coronaviruses, except the species of coronavirus there is not SARS coronavirus or MERS coronavirus. It's a little bit more of a benign variety called human coronavirus. And there are certain few numbers of how they are labeled, but there are a few human coronaviruses which have already been in human circulation for several decades. So within the coronaviruses themselves, the way your body responds to them depends on the virus. MERS coronavirus, the mortality rate is exorbitant. 34% of people who were infected with MERS ended up dying. With SARS coronavirus, the one that happened in early 2000s, the mortality rate was around 9%. So to bring that back and compare it with influenza virus, if you look at the data from a couple of years ago, there were about 64,000 people who died from influenza virus. But that was out of a total 44 million people who were infected. So the overwhelming majority of people with influenza virus ended up having a benign course. And already with coronavirus, there's been more than 64,000 people who've died. The native host of coronaviruses are bats. And coronaviruses don't cause as severe an infection in bats as they do in human beings. So the question is why? Well, because bats and coronaviruses have co-evolved over millennia such that bats have developed within their genetics certain changes in their T cells, in their inflammatory markers, or their reactivity towards the virus, so that they don't do the same things that human beings would, and they don't react to the virus the same way a human being would. On the flip side, coronaviruses keep evolving. Approximately 25% of its genome can be recombined, and the virus will still be able to replicate. But then that 25% recombination allows the virus to mutate much more than most other infectious organisms can. An ACE2 receptor, which was present in bats, because they're mammals, they also have the same receptors as human beings. And the part of the coronavirus's S protein, which would typically attach to that ACE2 receptor, mutated enough that it is now able to attach to our ACE2 receptor. And once it's able to do that, it can get into our cells through that receptor and then infect the cell. So let's talk about what happens when coronavirus enters our body and how it enters our body. If the size of the transmitting particle is under 5 micrometers, that's airborne spread. And tuberculosis, for example, is airborne spread, where you need to have a negative pressure room in a hospital to take away the air if somebody's admitted with tuberculosis. So with coronavirus, because it is larger than 5 micrometers, it has some weight to it, it will fall to the ground rather than staying afloat within approximately 6 feet, unless the virus is aerosolized. This typically happens in healthcare settings, and that's why it's critical that healthcare providers need to have N95 masks, because those masks can prevent the virus from being inhaled in. So the other means of droplet transmission, of course, is if the droplet falls into a surface which you touch. And that surface is called a fomite. The surface could be your cell phone, could be doorknobs, could be grocery carts. It's important to wash your hands for approximately 20 seconds because the virus's outer coat has a lipid layer, and just like oil in your dishes where you have to use soap to dissolve the oil, otherwise it stays stuck on there, because the soap breaks down the oil into smaller particles. Similarly, the virus's outer coat gets broken down by the soap, but this takes approximately 20 seconds, which is why you need to wash your hands for approximately 20 seconds. So let's talk about what happens when the virus gets inhaled. It goes down your trachea, splits into your bronchi, which are the main stem branches of the central trachea. And then within the lungs, on both sides, it goes into progressively smaller and smaller airways. And as the airways keep branching out, what this does is that it increases the surface area and it makes the thickness of the airway smaller and smaller, until at the very end you get to these very last branches of your airway, and there airways have what are called alveoli, and the alveoli increase the surface area even further, to the point that all you're left with the surface is just one layer of cells. The reason this is important is because when you have if you have the trachea in the center, that's got cartilage, it's got several layers, so obviously there's not going to be any exchange of carbon dioxide or oxygen that can go through a thick-walled tube. You need to have literally one cell layer thickness such that the carbon dioxide and oxygen that is in the air can be exchanged with the carbon dioxide and oxygen in your blood. So the alveoli serve that function. Now, in order for the blood vessels themselves to allow the exchange of oxygen and carbon dioxide, they too, once they get into your lungs, keep branching into finer and finer branches, which end up resulting in thinner and thinner thickness of the walls, to the point that eventually these blood vessels wrap around the alveoli in a network of very thin blood vessels whose thickness, again, is just approximately one cell layer thick, so that gas exchange can occur. So in the diagram we have over here, the blue cell represents the cell of your alveolus, which is the air sac, and therefore the coronavirus comes in from top and sits on top of the alveolar cell, and then it can infect it. On the other side, below the blue cell, you have a red tube, which is the artery. So how does the coronavirus get into the cell of the alveolus? Well, as we discussed, there's a receptor called the ACE2 receptor, which is on your alveolar cell, and the coronavirus will attach to the ACE2 receptor. And once it attaches, there's another protein called TMPRSS, which is a serine kinase, and it cleaves the S protein of the coronavirus. It facilitates the entry of the coronavirus into the cell, and once the coronavirus is in the cell, it releases its RNA into the cell's cytoplasm. That RNA then can utilize the machinery of your own cell, called ribosomes, to make protein. That's called translation. And that depends on the fact that we have a similar genetic code for all life. Once you have these proteins made, they're not functional proteins yet. There are enzymes in your cell called proteases, which break down this large protein that has just been created. Once the proteases have broken down this larger inactive protein unit into the smaller active units, there's an enzyme called RNA-dependent RNA polymerase, which will replicate the RNA of the coronavirus into multiple copies. And then these multiple copies of the RNA and the smaller active units of protein that were created go to an apparatus in your cell called the Golgi apparatus or the rough endoplasmic reticulum, which are part of the normal machinery of your cell, and take over that machinery to combine into units of viruses and get replicated into what are essentially active viral particles. The cell eventually will get filled with these viral particles, the cell gets damaged, and the viral particles can be transmitted into your bloodstream through the thin membrane which connects the blood and the alveolar cells. Once the virus gets into your cells, there are macrophages, which are blood cells in your bloodstream, which will pick up the virus, break it down, and pass on bits of the virus into other cells. The way they do this is through a protein called major histocompatibility complex. In human beings, that MHC complex is also called HLA, or human leukocyte antigen. And there's a huge what's called a polymorphism of the type of these HLA antigens and MHC complexes that most people have. And these are crucial to immunity. And there's some data that depending on what profile of MHC or HLA molecules you have, at least for SARS coronavirus and MERS, people were susceptible to different levels. And this might explain why some even younger people end up having worse infections. And it's unpredictable because we don't know, for most of us, what MHC complexes you have. In fact, these are so crucial to evolution and to survival that there have been experiments done where people find the opposite gender more attractive if their MHC complexes are of a different complement than what that person has. Because then if you have offsprings, both of you have very different types of MHC and HLA molecules, and then your offspring will have a very different diverse group of molecules which can help with their ability to fight infections. And people are not attracted to other people who have a similar set. So these are crucial to immunity. Again, so going back to the fact that now these antigen-presenting cells present little bits of the virus to your cell's lymphocytes, called helper T cells. And those cells then can do two things. One, they can transfer these antigens into killer T cells, which can help break the virus because now they've seen what the virus looks like through bits of viruses that they've been sensitized to, and they start attacking the virus directly. Also, they can convert into B cells, which can lead to the formation of antibodies. And these antibodies are specific to the antigen, which is the little piece of virus that has been shown to them. And each of us has billions of different types of antibodies to billions of different types of antigens that we've been exposed to through our lives, including all the vaccinations that you've received, or if you ended up having chickenpox in the past, you've developed antibodies to chickenpox, which will then stay active and will remember the virus the next time it comes in, and they will code it and they will present it to your body's immune cells. And for about 85% of people, this response is going to be sufficient to get rid of the virus. It can actually go in and infect the T lymphocytes that would have come to kill it. That's a direct invasion of the lymphocyte. It can also infect the bone marrow and cause a reduced production of lymphocytes in the bone marrow, resulting in a lesser ability of the body to get rid of it. It can actually go in and change your body's gene expression to reduce the number of antigen-presenting cells or make them inactive, such as the macrophages, so that the virus is not shown to other cells, and therefore the process which we just described doesn't happen as effectively as it should. So if the viral load is not reduced and the virus is not eliminated through the T cells and the macrophages and the antigen-presenting cells, the body then goes into a second phase. It says, okay, this is a serious infection. We need to get bigger guns out. And more macrophages and more inflammatory cells will come in to your lung tissue to try to attack the virus. To facilitate this process, you upregulate or increase the number of what are called cytokines. And these cytokines result in the blood vessel becoming more permeable or more open to allowing cells to go through the wall so that it can go from within the blood vessel itself into the target tissue, which is the alveolus, to try to attack the virus. What this results in is that not just the cells pass through, but also the fluid in your blood passes through the blood vessel and into the alveolus, because the blood vessel is a high pressure system through which the blood is being pushed through so that it can keep circulating. But your lungs are a space where air has to exchange. So if you get more fluid to fill within the sac of the alveolus, that's going to come in the way of carbon dioxide and oxygen passing through, and it will essentially clear a layer which will start suffocating the ability to breathe and exchange oxygen. Not just that, the excess number of cells that fill up the alveolus start taking up space. And instead of air filling the alveolus, now you have cells filling the alveolus, which again makes them non-functional. When the type 2 pneumocytes get damaged by the virus and through this entire process, they normally secrete surfactant, which allows the alveolus to stay spherical by reducing its surface tension. Once the type 2 pneumocyte is damaged, surfactant goes away and the alveolus doesn't stay open anymore. All these factors essentially make the lung less able to do its function of exchanging oxygen and holding on to air in these alveolar sacs. Now, all of these cytokines that have been released, such as interleukin 1, interleukin 6, TNF alpha, interferon 1, these are all different names of cytokines. They're released into your bloodstream. So they don't only cause increased permeability or ability of the fluid to leak out of your blood vessels in your lungs, but also everywhere else. This results in the circulating volume of blood being reduced within the blood vessel. You may lose fluid into the space outside the blood vessel, but the blood vessel itself doesn't have as much fluid as it did before, and therefore the blood pressure will drop. So what that does is that your organs, your brain, your heart, your kidneys, your liver, can start going into shock because they don't get the blood pressure that they need to keep functioning. And you can start going into organ dysfunction and what's called multi-system organ failure if your blood pressure doesn't improve. Not just that, the virus can have direct toxicity in all of these organs and cause damage within the organs themselves, such as with your heart. The virus can cause what's called myocarditis. As we discussed, the virus's target is the ACE2 receptors, but these receptors are not just present in the alveolus, they're also present in your gastrointestinal system, and they're also present within your blood vessels. In fact, one of the most common treatments for hypertension are what are called ACE inhibitors, which block this receptor so that the blood pressure can go down. But because these receptors are also present in blood vessels, the blood vessels themselves can get damaged, and the virus can cause what's called microangiopathy, which is essentially damage to the smaller blood vessels, and that can lead to clotting problems. If you have clotting problems, that can lead to strokes and heart attacks, because if the blood vessel gets filled with a clot, it can't allow the blood to go through any further, and if the blood doesn't reach the heart or doesn't reach the brain because it's blocked because of a clot, that will lead to damage in the brain and the heart, and that's what a stroke and a heart attack are. For symptoms, as you can imagine, there's a cough, just like with any upper respiratory tract infection. There's going to be a fever in the majority of people who have this virus. It may not present as one of the earlier symptoms, but at some point people will develop a fever, which is again common to viral infections. And of course, once you start developing more severe disease, and one of the signs that you need to go to the hospital or you can't take care of this at home anymore is once you start getting dyspnea or shortness of breath. Because shortness of breath is suggesting that enough of these alveoli within your lung have been damaged to the point that your oxygen level is starting to drop. Of course, if you have one of the more rarer complications, such as a heart attack or a stroke, you may present with one of those. What are the lab investigations that you'll find? We talked about how the blood cells, the lymphocytes, get attached. So you can have one of the most common lab investigation findings with coronavirus is what's called lymphopenia, or low lymphocyte counts, or leukopenia, low white blood cell counts. If you have damage to your liver, you will have elevation in your liver enzymes called AST, ALT. If you have blood clotting problems and you have inflammation in your body in severe infections, we'll start seeing an elevated level of inflammatory markers in your blood. These inflammatory markers include what's called D-dimer, LDH, ferritin. If somebody has a heart attack or if they have toxicity and viral infection affecting and causing inflammation in the heart's muscle, what we see very often in people with severe coronavirus disease is an elevation in their heart's muscle enzymes called CKMB or troponin. Moving on to imaging investigations, the most commonly used ones for coronavirus are chest x-rays and high-resolution CT scans. The chest x-ray will show fluid collection within the lung. Normally the lungs are black because they're filled with air on x-ray. And when somebody has a pneumonia or they have fluid in their lungs, then because the sacs of air, the alveoli, are filled with fluid or filled with blood cells or macrophages, secretions, essentially they become lighter, and you can see that on a chest x-ray. On a CT scan, the same thing happens, except you see it in much more clarity. And depending on how much of the lung is infected or affected, the chest x-ray and the CT scan can look horrible, much more so than what we see with most other viral infections or bacterial infections. If the person's heart is involved, sometimes on an electrocardiogram, we could see signs of inflammation of their heart's muscle or a sign of a heart attack where one of their arteries might be blocked. So then how is coronavirus diagnosed? Well, you look at the overall picture, the history, where the patient's coming from, what their exposures are, whether they had a cough. You look at the laboratory investigations, if they have lymphopenia, if they have D-dimer elevation, and some of the other lab work that I mentioned. You look at their chest x-ray, look at the CT scan, and putting it all together, you can make a whole diagnosis of what's going on with this person. The more confirmatory diagnosis, because there can be other causes for all these symptoms too, to know for sure that this is because of COVID, the most used and accurate test that we have right now is called real-time polymerase chain reaction, or RT-PCR, which essentially goes back to where we discussed the viral replication happening within the cell. We can check for viral units through this process. The other way that we can diagnose if somebody has had coronavirus is by checking for the presence of antibodies through what's called an ELISA, or enzyme-linked immunosorbent assay. And that can amplify the amount of immunoglobulin somebody has and see if they've gotten immunity to the virus already or not. And of course, they would only have immunity if they've been infected by the virus. Let's now try to talk about how we're trying to treat this virus, including some of the experimental therapies, and then we'll talk about the standard therapies. The first step, of course, is prevention of the virus entering your body, and that includes everything that we're doing. That's why our society is in a mode of lockdown. We have social distancing, hand washing. We try to prevent being infected or spreading the infection or the virus to anybody else. Now we'll talk a little bit more about some of the experimental therapies. We talked about how the virus attaches to the cell and how TMRSS2 is part of what facilitates the virus's entry into the type 2 pneumocyte. There's a drug called camostat mesylate which can block this TMRSS2 so the virus doesn't enter. Chloroquine also acts at a similar step to prevent viral entry. Once the virus gets in, we talked about how it causes a protein to form, and that protein gets broken down into smaller units through enzymes called proteases. And those proteases can be blocked so that these active smaller protein subunits aren't formed. You may have heard of lopinavir and ritonavir being used as experimental drugs, and those drugs are protease inhibitors. The next step was the virus making multiple copies of itself through RNA-dependent RNA polymerase. That enzyme can be blocked using drugs called nucleotide analogs, and remdesivir and ribavirin, which is not quite as, doesn't have as much evidence, are examples of those type of drugs. We talked about how our own body's response with the release of cytokines, which is called a cytokine storm, is counterproductive in many ways and leads to excess fluid deposition within the lungs, reduction in blood pressure, and multisystem organ failure. One of the cytokines which is a big player in this process is called interleukin-6. This can be blocked using an antibody, and that's called tocilizumab, which is a monoclonal antibody which blocks interleukin-6 and prevents the cytokine storm. Another therapeutic option to block this cytokine storm is the use of what's called IVIG, which is intravenous immunoglobulin. These drugs, we don't really know necessarily how well they work and whether or not the safety versus benefit risk ratio is in favor of using them at this time. The other therapeutic option is the use of what's called convalescent plasma. And what that is essentially the antibodies that we talked about. We discussed how the antibodies are very specific. Person A gets infected, develops antibodies to the coronavirus, is the same coronavirus that might infect patient B, and the antibodies therefore will still be active in acting against the coronavirus because they were made specifically for the structure of coronavirus or a part of the structure of coronavirus. And therefore, if you transfuse antibodies from person A into person B, you could give them an immunity boost to try to get rid of the virus. Instead of an actual virus infecting person A and then causing disease and having to wait for somebody to have antibodies form, what the vaccine does is that it, instead of giving an active virus, it gives a portion of the structure of the virus or the RNA or the DNA of the virus or a subunit of the virus into a healthy individual, so that a healthy individual can develop these antibodies by seeing these parts of the virus, which are the antigens, and develop antibodies towards these antigens so that they themselves can be protected if they ever get infected with a real virus, which is active. The main reason vaccines will take a long time is, as you can imagine from that description, whatever you're giving to the person has to really be inactive, and it cannot be something that will actually cause disease, because then you're infecting people who are otherwise healthy. So the safety profile of the vaccines is a big concern, and part of the reason that it needs to be tested. Of course, if you have a mild infection, you treat with time and controlling the fever and your symptoms. People who develop a more significant infection, let's say people develop shortness of breath and need to come into the hospital. As we discussed, shortness of breath can be a sign of decreased oxygen saturations. So what that could imply is that somebody needs supplemental oxygen because some portion of their lung tissue, the alveoli, are not functioning and exchanging oxygen. So if you give supplemental oxygen, then whatever alveoli are working, if they see higher concentration of oxygen coming into them, more oxygen can be exchanged with the blood and can maintain adequate levels of oxygen so that the person can live. Of course, if that gets worse, the supplemental oxygen through the nasal prongs of the face mask may not be enough, and the person may need to be intubated, where air is pushed into the lungs. And what that does is it splays open the alveoli, and also it can deliver higher FiO2s, or percentages of oxygen. Up to even 100% oxygen can be delivered through the ventilator. Another thing we had talked about with what can go wrong is with the inflammatory response, the cytokine storm. As you're losing fluid in your blood and your blood pressure is dropping, people can get intravenous fluid rehydration so that they can maintain their blood pressure. This can be a cyclical problem because, as you can imagine, the lungs are already drowning because they're not exchanging oxygen adequately. And if you give a patient whose blood vessels or vasculature is already leaky extra fluid because the fluid in the blood vessels isn't enough, eventually some of that fluid can seep out again and go into the lungs and make the problem worse. So it has to be done judiciously. And this starts giving you an idea of how tenuous this balance can be, because we already have very little lung space, which is actually functional in people with severe COVID. And if their blood pressure is dropping, it can be very hard to manage them and to make sure that the organs are getting enough blood and enough blood pressure. We talked about how you can have clotting problems, and in some people, if they end up getting a heart attack, this happened to one of my patients where I got called about a person with an electrocardiogram that showed that they were having a heart attack because a portion of their heart muscle was dying. And we knew that they had had a cough. I went and saw their CT scan and looked typical for what COVID would look like. Both sides of the lungs with multiple areas are filled with sections where there's been damage to the alveoli and they're filled with fluid. And even before I saw the patient, it was clear that the person had COVID, and they did eventually end up having it. The options there are to either give blood thinners, which are very potent, to try to open up the clot, or end up taking the person into what's called a cardiac catheterization lab, where we go into the artery and open it up, and this person ended up having that problem. So that's called percutaneous coronary intervention, or stenting. As we discussed, the problem with COVID can be cyclical, especially once you develop acute respiratory distress syndrome. In some people, the cytokine storm and the inflammatory response, the amount of pneumonia can be so overwhelming that almost the entire lung gets involved. And once that happens, there can be almost no tissue left, or not enough tissue left to maintain an oxygen level which is compatible with life. And that is one of the main reasons that so many people are dying despite all the best medical therapies. And as we discussed, the factors that lead to somebody having a more severe infection, to having a severe cytokine storm or acute respiratory distress syndrome, are not always predictable. Now, if we are in a situation where enough of the lung tissue has been compromised that oxygen saturation cannot be maintained despite the use of ventilators, the final option there is to actually oxygenate the blood, not inside the body using the lungs, but to take the blood out and oxygenate it using a machine. That's called ECMO, or extracorporeal membrane oxygenation. What we would do, and can be done by interventional cardiologists like myself, or vascular surgeons, or cardiac surgeons. The way this is done is a circuit is created where the blood is taken in and out of the body. This could be done through the internal jugular vein in the neck or through the femoral vein. That circuit is called a VV ECMO, or a veno-venous ECMO. There's also a VA ECMO, which is usually used in people primarily with cardiac problems rather than oxygenation problems. But as you can imagine, this is very resource intensive, and whether or not it's used is on a case-by-case basis and depends on whether or not there are people who can provide that service. So finally, let me just encourage you by saying keep up the great work that you're doing, because in this situation especially, prevention is definitely better than cure. I hope you found this review useful, and if you did, then please share it with your friends and your family, because it's always good to share knowledge. Thank you. I hope you stay safe, stay healthy, and I will see you next time.